Just go to the green button down, press. On there is something called share screen with the green arrow.
Wait 1 second, because I've lost you now.
Do you see the green button down on your screen?
No.
Okay, wait, just
because I've lost the screen now. Just have to. Because I was in the.
Do you see the question and answer box? Yeah. Okay.
Somehow I need to get back to my screen. I don't know why I have it here.
What is your laptop? Is it like Mac or Mac? Go all the way up and open all desktops that you have. So you will see the Zoom in one of those windows.
Yeah, I'm just looking for it.
Do you see? Can you stop your mic and you see the?
Yeah, I have to. Maybe I have to look at the invitation again and to.
No, it's okay. Do you see the mic? Do you see the mic in your left? There is a mic and video.
I have lost the screen with the Zoom. I don't know where I have put it. It disappeared. That's the problem.
Okay, I will try to show you something. Just a minute. I'll share my screen.
I can't see you either.
Okay.
Now I can see. Yeah. No.
This is my screen. This is my screen now. Okay. If you just go like this in the top, see I am going on all the way in the top with the Mac with the 3 fingers, and you can see there is. You will see the Zoom on top here.
Okay, and then I do.
And click on that screen and try this way. If not, then I have to ask you to log out and log in again.
Okay, now I have it, I think.
Okay.
Can you see it now?
Yes, very clear.
Now it's okay.
Very good.
Okay.
Now.
So.
Very.
Thank you very much. Okay. So, dear colleagues, it is a great honor for me to be invited to your Congress. And I would like to thank Professor Alesa for inviting me and share with you some of our thoughts on how we treat soft tissue defects at teeth and also at some particular situations around implants. And I would like to discuss with you some of the indications for treatment, some of our goals, our factors that may influence the outcomes, and then to elaborate a little bit on the single and multiple defects, especially on how we started since many years to treat those defects in burn. And then to show you also some cases at lingual defects and some other cases around implants. And let me share with you some cases. Look at this particular patient that shows a soft tissue defect at a lower central incisor. She has difficulties in cleaning, obviously, due to the lack of bone, lack of soft tissue. And in many cases, if we do not perform an adequate treatment, the tooth may be lost. And of course, another case, you can see a comparable situation. This is a post-orthodontic case with an active retainer. And please observe again the same problem. And I'm sure that many of you have certain situations that are similar in the daily practice. If the case is more advanced and we have also a so-called traumatic component like an inserting frenulum, or maybe a piercing that I will show in a minute, we may also exhibit a periodontal attachment and bone loss, which may eventually lead to tooth loss. Please observe in this particular case, the piercing device that has a nice plaque accumulation, and this has also contributed to the loss of supporting tissues. And obviously, the most important in such cases is to help the patient to clean. Please observe the situation in a case with a severe loss of hard and soft tissue. And after my treatment, we have completely reestablished the lost hard and soft tissues. And the main goal is not necessarily the aesthetic improvement in this particular case. Of course, the aesthetic is also better. However, what we would like to obtain is, in fact, the possibility for a patient to clean much better. So the indications for treatment is, if I would summarize them, first of all, is to improve the possibility to perform an adequate oral hygiene in order to prevent gingivitis, to prevent root caries, to improve the aesthetic outcomes, and in certain particular cases, to treat hypersensitivity. Please again observe two particular cases. To the left, we see a situation where we have a loss of soft tissue, and again, the difficulty for this patient to clean. And to the right, we have now, again, a comparable situation, but now the defects are located in the upper jaw. And what we can observe is an inesthetic appearance, although the patient in this particular case can clean very well. The first step is to look at the potential etiologic factors. And these can be very different. They can be related to a mechanical trauma. They can be related to periodontitis. Of course, also our periodontal therapy, when we reduce the pockets, will decrease the depth of the pockets, but in the same time, we will have a recession. We may face also a post-orthodontic situation, which means that after completion of an active orthodontic therapy, we may observe a loss of soft tissues and hard tissues, combined with a bony dehiscency, but sometimes you have a very small accident, or maybe a pool of muscles, frenula, or even a trauma due to piercing. Unfortunately, in young people, we see these kind of situations. And please observe exactly at the opposite side, a loss of the soft tissue. And this is, in many cases, difficult to clean for a patient. If I would summarize our treatment goals, the first and most important is to reestablish periodontal health by optimizing biofilm control. Of course, I would like to completely rebuild the lost tissues, so-called 100% root coverage. But in the same time, I would like to avoid niches. In other words, I would like to avoid any residual probing depths that may exceed 3 millimeters. For this, we would like to enhance periodontal regeneration. In other words, formation of root cementum, periodontal ligament, and bone. And the tissue quality, the tissue blending and color should be also a kind of natural tissue. In other words, even if an expert would look at the outcomes, there should be no difference, at least no visible difference, between the treated and the so-called pristine sites. And of course, I would like to avoid as much as possible formation of scar tissue. And you can see one example, one patient that I treated about 10 years ago. And after 2 years, please observe the situation indicating very stable soft tissue condition. The factors that may influence the outcomes are the following. First of all, the patient, because we are dealing with anatomical factors such as the tooth, the bone, and the soft tissues, but also our surgical technique. And of course, some other factors like smoking habits, like general diseases, may also influence the outcomes. When we are dealing with such a defect, it is very important to keep in mind the biology of periodontal wound healing. And you can see it on this slide. The wound healing, in other words, the regeneration process, is a rather fast phenomenon. And during the first 2 to 3 weeks, all the new tissues will reform, which means that we need to stabilize the blood clot. How do we do that? By our surgical technique, by using certain biomaterials, by using a graft, preferably an autogenous graft, harvested from the palate, or sometimes you can use some soft tissue replacement materials, and a very precise, traumatic, and tension-free suturing technique. And then we help, in fact, the body to heal, because the defect will heal by itself. We just have to give the appropriate support. So what do we understand when we talk about periodontal regeneration? As you can see it on this slide, we understand formation of new cementum, new periodontal ligament, and new alveolar bone on the previously plaque-infected root surface. So the treatment concept is as follows. We would like to stabilize the blood clot to enhance wound stability. I try to avoid as much as possible vertical releasing incisions, because in this way I optimize the blood supplies. Then I would like to use some biologic materials that may help to enhance periodontal wound healing and regeneration, such as, for example, enamel matrix proteins, or nowadays we may use also hyaluronic acid. In order to stabilize the flap, to stabilize the papilla, we need also certain materials that enhance tissue thickness, tissue volume. Usually we use connective tissue grafts harvested from the palate. And of course, the tension-free flap adaptation and suturing is also mandatory. So if I would elaborate between the single and multiple defects, if we look now at single defects, first of all, we look at the phenotype of the patient. In other words, we look at the thickness of the tissue. If we are facing a thin tissue, then of course, we need to increase the tissue thickness by using a graft. Otherwise, we just work with the soft tissues surrounding the defect. However, in most cases, the problem occurs between the tissue is thin. This is the easiest way on how we detect and diagnose the phenotype. Just place the probe between the soft tissue and the tooth, and if you can see the probe shining through the tissue, we need a graft. We need to thicken the tissue, for sure. So what do we use? We tried in the last 12 years to modify the tunnel approach, and we call it a modification, the so-called modified coronally advanced tunnel. And why do we call it modification? Because first of all, we prepare a full thickness flap, and then we move the tissue coronally. So we do not start in a so-called split thickness approach. With this way, we have a very good vascularization, an excellent survival of the graft, and an optimal increase in soft tissue thickness. And also the tissue color and blending will be very nice. For this, we need specially designed instruments. And these are the so-called tunnel instruments or tunnel blades that have different shapes. And in other words, they are like small periosteal elevators, very sharp, and we can prepare easily the flap, the soft tissue. Let me share with you some cases. Please observe this upper canine. We have here a rather thin tissue. Obviously, we need to thicken the tissue with a graft. So I prepare the full thickness tunnel, move the tissue beyond the mucogingival line in order to have a tension-free mobilization. Then the flap is basically moving coronally without any tension. I use my connective tissue grafts, eventually in combination with a biologic material. I suture it, fix it, stabilize it, add the cement enamel junction, and then I move coronally the soft tissue in order to cover completely the graft and the recession. And please observe here the situation after 3 years, a very nice and stable clinical outcome. We cannot even see where this defect was before. If we move now to the lower jaw, the situation is more difficult since we have also the pull of the muscles, of the frenula. Nowadays, I do not perform, at least in most cases, a frenulectomy. I do it during the tunnel preparation. I have a so-called internal frenulectomy, and I will show you some other cases. So what I perform in this case is a full thickness flap, releasing the fibers from the inner side, placing the connective tissue graft, fixing it with a sling suture. It is very important that the graft doesn't move at all, and then submerge it with a soft tissue. And please observe at 4 years, a very nice and stable outcome, indicating that we have a good healing. The probing depth is maybe 1 millimeter maximum, and a very nice clinical outcome. We also published our data, and now we have more than 950 cases that I treated myself in the last 10 years. And you see that in single isolated mandibular recession, I have obtained with my technique about 96% complete coverage, which is very, very good. However, in certain cases, the situation is more difficult. What does it mean? That we have a very deep mandibular recession. And in this particular case, it is very challenging to move the soft tissue coronally without having any tension. So we developed and described a new technique together with my good friend, Dr. Pat Allen from USA. And we termed it laterally closed tunnel. Why? Because in fact, we move the tissue laterally and not coronally. It has certain advantages. First of all, we don't have vertical releasing incisions. In other words, we have a better blood supply. We enhance the wound stability, and we do not have, or very limited, decrease in vestibulum depth. So let me share with you some cases. This lady was referred to me from Luxembourg. You see the problem, very deep defect reaching almost the apex. We have here plaque accumulation. She has difficulties in cleaning, and we have to help her. Otherwise, she may have even an endodontic problem over time. So what I do is to prepare a full thickness tunnel, preserving the papilla, and then extending the flap in a way that I can move it together. I remove the fibers that insert in the tunnel from the inner side, place the graft and fix it at the cemental junction, and then close the flap with single interrupted sutures. Let me show you the healing after 3 years, a very nice outcome, complete coverage without changing the depth of the vestibulum. Another particular orthodontic case, please observe the frenulum that inserts, and again, this patient has difficulties in cleaning. Please observe the steps. I mobilize the tunnel, reflect a little bit the papilla from the inner side because we need to stabilize the central papilla. Place the graft, and instead of suturing the tissue coronally, I close it very, very carefully laterally. And we have, again, a very nice outcome, 100% coverage, and we don't see any scar tissue formation. Let me share with you a video. This was a very, very difficult case, 1 centimeter deep, 10 millimeter recession, and we had a 4 millimeter pocket depth, indicating 14 millimeters of attachment loss without having any attached gingiva. And you see the situation. it is a very deep and very wide surface. And only a couple of years ago, such cases were not possible to be treated in one single step. So what I do is, in fact, to use microblades. And these microsurgical blades are placed intrasulcularly. We bevel a little bit the blade, and in this way, I have a bleeding surface, so I do not need to de-epithelialize this area. Then I have an easier way to access and to prepare the tunnel. And please observe how thin the tissue is. In other words, the instrument, the tunneling instruments, need to stay on the bone. This is very, very important, because otherwise I have a higher chance to perforate the flap. And you can see this movement with the blade. This is a 15C blade, and I move the blade in contact with the soft tissue. And this is very important for releasing the tension from the flap. And then if I still have some tension from the lip, I go with my microblade, and I release the fiber from the inner side. Then I place the regenerative material over the root surface. Combine it with my connective tissue graft, and you can see that the connective tissue graft is fixed with a sling suture exactly at the cementum junction. It is very important to be precise with our sutures. And please observe that I move the needle always with the reverse part under the embrasure. This is very important. And I fix the graft in a way that we do not have any mobility. This is extremely important in these cases. Then, if available, I place another layer of the regenerative material over the graft, and the suturing of the soft tissue or the graft is very simple. So what I do is to use a single interrupted suture, starting with the suturing from apically and moving, in fact, coronally. I always take care that I do not touch with the tip of the needle the graft. This is very important. And the big advantage of the graft, of the autogenous tissue, is that we can leave part of it open. However, we need to submerge about 2/3 of the graft. Please observe the situation after about 2 years compared to the baseline, and you can clearly observe a complete coverage of the recession, very nice color, and the probing depth is about 1 millimeter. We have a very good tissue stability. Please observe another case. This is a case that was caused by a retainer, and this retainer was active. So what we have to do in certain situations is to look also from an incisal edge at these particular situations. And please observe that the position of the central incisors are different, of the two central incisors. One is a little bit more labially, whereas the other one is in the correct position. So most probably we have a problem with the retainer. And in this case, I always contact my orthodontist, Professor Katsaros from our dental school. We work very closely, and we treat such cases always together. So what we do is to move a little bit the root lingually, to replace the root a little bit more into the bony envelope if possible. This may take sometimes up to 6 months or even longer, and only then reevaluate the case. You can see the difference in the size of the recession. However, we have eliminated the cause. What we do now is, in fact, to prepare the flap, the tunnel, keeping the papilla, preserving the blood clot, stabilizing the area, and then I remove the fibers from the inner side. And please observe that the defect reaches almost the apex of the tooth. Then, of course, using the connective tissue, in this particular case, I used hyaluronic acid. that has been shown to promote very nicely the healing, and suturing the flap laterally. A slight portion of the graft was still open, but this can heal very, very nicely. And please observe the outcome after about 1 year, indicating a complete coverage. And together with Dr. Allen, we published also results in very challenging cases, all of them treated by myself with this technique. And we had a very good coverage, almost in every case, 100% root coverage. What do we do now in multiple defects? In multiple defects, if you look at the literature, we have different techniques that have been used and evaluated. And in fact, 2 techniques have been shown to be quite successful and predictable. One is the technique described by my friend, Professor Zucchelli, is the so-called modified coronally advanced flap, whereas the other technique is the so-called modified coronally advanced tunnel that we can use either without or with grafting, depending on the tissue thickness. How do we move on when we use the tunnel approach? Because this is my technique that I favor, and I would say that in more than 95% of my cases, I use this technique. So in other words, I prepare the full thickness tunnel. Of course, we need to clean the root surfaces. Eventually, we need to remove small composite fillings if this is needed. Prepare the tunnel, move the tunnel beyond the mucogingival line, make sure that we can have a situation without any tension. We may condition the root surface using DDTA, place a regenerative material, either emdogain or hyaluronic acid. And if we look now at the connective tissue, the connective tissue is extending from the mesial to the distal recession, maybe 1 tooth mesially, 1 tooth distally, depending on the situation. Fix it exactly at the cemento-enamel junction and submerge it with a tunnel. That's why we call it coronally advanced tunnel. And please observe the situation 8 years later. Very stable, very nice. Maybe the canine is not perfect because it receded a little bit, but we have a very good stability, and also the aesthetic outcome is very pleasant. And in our pool, in Miller class 1 and 2 defects, we obtained almost 100% coverage, also in multiple defects. However, what do we do in mandibular multiple defects? Because this is even more challenging. In fact, if I have a situation, as you can see here, what we do is to extend the tunnel, but here we have also loss of the papilla. So in such a case, I extend the tunnel. Please observe we have almost no keratinized tissue at all. I release the fibers from the inner side because I have here multiple inserting frenula, but we need to have a long graft. And in such a case, I use a so-called palatotuberal graft that I insert in this area, and always the largest part of the graft will be at the area where we had the 2 central incisors in order to stabilize exactly the central papilla. And then I move very gently, closing the flap laterally and coronally. So we alternate a lateral with a coronal closure. And in this way, we have a very nice and predictable outcome. So stabilize the area. Now look at the healing after 2 years. It is very nice, very predictable, and we obtain an almost complete root coverage in every single case. Look at this case. This is a lady that had multiple recessions, and these were treated with composite fillings. So what I do in such cases is, first of all, to teach the patient to clean. Her main problem was that she had pain while cleaning. We remove the composite fillings, and please let me show you this video. It is very important to look and to analyze the surfaces and to make sure that we don't have infection, we don't have bacteria on the root surface. That's why I like to clean the root surface. This is the so-called internal frenulectomy, dissecting the fibers, eventually also dissecting the muscles that insert from the lip. And then, of course, I need a longer graft. And please look at the harvesting technique. I use the so-called single incision technique, starting at the most distal part, if I need a long graft, at the most distal part of the palate, at the distal part of the last molar, and then I dissect, in fact, the epithelium from the underlying connective tissue using a 15C blade of, or maybe also 15. And I keep the blade always in contact with the epithelium. It is very important to analyze the consistency and the anatomy of the palate, because in patients with a shallow palate, the palatal artery is closer to the teeth. So we have to be cautious. And then I move my blade in contact with the bone. If I have enough thickness, I just leave the periosteum there, because then the healing is even better, is even faster. And I dissect the graft of a thickness of about 1.5 millimeters, maximum between 1 millimeter and 1.5 millimeters. What we have to keep in mind, dear colleagues, is that the graft is a biologic material, contains cells, contains growth factors, and we need, in fact, also the apical, the deeper part of the graft, because in the deeper part of the graft, we had, in fact, a lot of growth factors that may positively influence the healing process. Please observe that the papillae keep the entire complex very stable. So what I do in such a case is to look at the graft, to trim the graft is necessary, but always the widest and thickest part of the graft is going to be placed in the central portion, stabilizing the central papilla. Then I use, in difficult cases as this one, always a regenerative material. And this material will be placed on the root surface from apically to coronally in order to attract the surrounding fibroblast and also the periodontal ligament cells towards the root surface. And of course, then I move gently with my needle under the papillae, and I pull the connective tissue graft, or my assistant is pulling the connective tissue graft. And we make sure that the graft is not rotating, is not turning in the tunnel. This is very important because we have to have a graft that is facing the surface of the tooth like a membrane. So we pull the graft in the tunnel, then I have the first suture, I suture and fix the graft at one place, I pull the graft into the other direction, and then all of a sudden the graft is going to be stretched. Then we have to move on with the next steps. And these are the fixation sutures, because these sutures will fix the connective tissue graft exactly at the cemento-enamel junction. How do we do it? It is very easy. We start lingually, we capture the graft at the line angle buccally, and then we move back the same way we came, fixing the graft lingually with the suture. And this suture we pull the graft coronally, and we'll fix it exactly at the desired position. So once the graft is fixed, I start to move the flaps or the tunnel together. If we are facing a deep and narrow defect, I move laterally with single interrupted sutures. As you can see it here. For this technique, we need short needles. This is very important because if I have a long needle, I cannot move my hand very good. So I need maybe 12 millimeter long needle and I can guide my needle much better. How do I guide my needle? Also by using a periosteal elevator, a special designed elevator that is in fact protecting the needle and the graft. So in fact, I guide my tip of the needle and I'm much more precise in my suturing. However, if I face several recessions, we alternate the coronal advancement of the tunnel with the lateral closure. Please observe in this particular case, the outcome after 2 years, very, very nice, without having any scar tissue formation. And this was a quite challenging clinical situation. Let me go to the next points. These are some maybe challenging cases and some cases around the implants. So what about root coverage at teeth that are covered with ceramic crowns? Because all of us have these problems. The patient receives some nice crowns, and after a couple of years, we can detect the margin of the crown. And when the patient is smiling, the aesthetic appearance is not very nice. How can we fix it? Of course, we cannot prepare always a new crown because then we are going to change the shape of the tooth and of the smile design. We need soft tissue. So what I do in such cases, if the crown is well made, we just preserve it. If, of course, if we have an overhang, then we need to have a new crown. Then I prepare the tunnel, move it coronally, use a connective tissue graft and submerge it. Exactly the same technique as you have seen before, but we have to advance it a little bit more coronally. And then if you look at the outcome after 2 years, in this case, the crowns are the same. We have a very nice and pleasant aesthetic appearance. Look at this particular case. Here we have an implant that was placed by Professor Buzer and the crown by Professor Belzer, and the neighboring tooth has a crown. However, the problem was that the crown at the lateral incisor was a little bit too long, and the patient was unhappy with the symmetry of the lateral incisors. What can we do in such a case? It is very difficult to have a new crown because we don't have red tissue. So the crown was perfectly made. What I did is, in fact, to graft the area with the soft tissue and move it coronally without any tension. And this is very important, using an autogenous tissue, because in this way I can control much better the healing process. And if you look now at the outcome after about 1 year, we have very nice outcome, and we were able to cover about 2 millimeters. Please observe the difference in the tissue, and we have reestablished, in fact, the symmetry. And by this technique, we have obtained quite good outcomes. You see mean root coverage more than 90% at maxillary over crown teeth, and the tissue gain of almost 4 millimeters. Look at this case. Sometimes I face problems, and I think that all of us have these cases, where we have lingual multiple defects, and these cases are very challenging. Until now, with the tunnel technique, is almost no report in the literature. So I did a case series that will be soon published, and I developed a technique in order to try to address these cases, because the patient has difficulties in cleaning. This is the main indication. We need a thicker and stable tissue. So what I do in such a case is to prepare a full thickness tunnel from canine to canine in this particular case. We have to stay on the bone because we have the artery. We don't have to hurt it, because then we have a severe bleeding. And then lift the papilla. Of course, I use a connective tissue graft. And please observe the suturing technique. Technically, it is, of course, more demanding, but we can have a very nice outcome. And in this case, we have 100% coverage of all defects. What about recession coverage at dental implants? We did a literature review a couple of years ago. Not much change since then in the literature. And the literature revealed that only shallow defects can be predictably covered in cases where the implant is positioned in a more or less correct position. However, if you have a very deep and wide recession of the implant, the biology of the healing is much more difficult because we have a very large vascular surface, usually is also contaminated by bacteria. We don't have periodontal ligament and we have a scar tissue formation. So in other words, we treat only shallow defects, maybe up to 2 to 3 millimeters. So what I did in our treatment concept is to implement the tunnel approach that I learned and developed around teeth to cases around implants. And we may face very challenging cases. Look at this particular case, very deep defect. The crown is very poorly made and the implant is wrongly placed. This is, dear colleagues, a mission impossible. Here we need to explant. Otherwise, it's not possible to cover it. The diagnosis and the treatment planning are the most important steps. However, if I decide to cover, then I use a tunneling approach. And in this particular case, as you see it here, we have in fact a smaller defect, a dehiscence and the fenestration. And here I did the same approach. Of course, it is very important to detect whether we are facing a periimplantitis or not. These are cases without periimplantitis. I use the same approach as you have seen before, and using the connective tissue graft, I was able to cover the defect with about 2 to 2.5 millimeters and improve the situation of the soft tissue. And let me show you a small video. This was a case that was treated with a 12 millimeters long Straumann implant. The implant is in a correct position. However, if we look at the situation of the soft tissue, there was no enough attached mucosa, probably before placing the implant. That's why, dear colleagues, it is very important to make sure that we have at least 3 millimeters, 2-3 millimeters of attached mucosa, not only bone, but also mucosa before we place the implants. Otherwise, we may face a similar problem. So in such a case, I clean the implant surface. This is a case without periimplantitis. This is very important to detect. I may use some hand instruments, but nowadays I prefer to use some air polishing devices because they can remove very nicely the biofilm from the surface of the implant. I incise with a microblade in the sulcus, and then I use a tunnel instrument. Please observe, in this particular case, I connect the soft tissues from the teeth to the soft tissues over the implants. And this is very important. Sometimes if you are facing implants, especially in the aesthetic area, the tissue is more challenging to manage. Why? Because we had already one or maybe in some cases even 2 surgeries due to implant placement, due to guided bone regeneration, and the tissue is more fibrous, it is more scar-like tissue. So we have to make sure that our tunnel is well prepared. We don't have inserting fibers that may in fact have a inhibitory effect or block in fact the pulling of the connective tissue. This is very important. So I insert the connective tissue, fix it at one end, stabilize with my connective tissue the papilla, and then I take the other side of the connective tissue, engage it with a metal suture, and then gently moving back and stretching, in fact, the connective tissue over the surface of the implant. This is very important. So I make it, in fact, in a way that we can stretch it very, very nicely. You can see it here, very, very gently. Stretching it. Now I have the graft, I have the living cells. Then the next step is to fix the connective tissue graft with our sling sutures. Having the suture lingually without passing through the connective tissue of the papilla with our tip of the needle, and again engaging the graft from the buccal surface. And in this way, I pull a little bit the graft coronally, I fix it exactly at the CG, and ensure a very good stability. And now the next step is to move it, to move the edges of the flap together. Very, very gently. Always engaging the connective tissue, so not the connective tissue, the flaps. And I move them laterally or coronally. And again, the advantage of the autogenous tissue is the fact that I can leave, if needed, a very small portion open. And this is the only advantage of this tissue. Because if I take another tissue type, for example, I take a membrane, alloderm, whatsoever, and I leave it open, then it will lead most probably to an infection, plaque accumulation infection. So that's why the connective tissue is a kind of forgiving tissue. Please observe the suturing, very stable situation. Nowadays, I keep the sutures sometimes even for 3 or 4 weeks, if I have the feeling that the situation is not stable enough. And look at the healing, we have an increased width of the keratinized tissue, very good stability, and the small hole is completely gone. We have a complete coverage of the defect, and the patient can clean very well. And the crown is still the same. So let me come to some conclusions. I hope that I was able to convince you that our techniques are very predictable. We offer some courses in Bern. You can join them if you wish, because once you have learned it, it's quite easy to perform. It is very predictable, especially also in Laojo cases. Please don't forget that we need also attached mucosa around implants. It is very important. Don't forget that we need hard and also soft tissue, because if the patients have a sufficient attached mucosa, at least 2-3 millimeters, the clinical stability and the cleanability of the area is much better, especially in the posterior areas. What about recessions? Current evidence suggests that the biology at implants is not the same as around teeth. And recession coverage can only be obtained at small defects at implants, 2 to 3 millimeters, but in impossible cases, probably implant removal or some other techniques are more predictable. So it is very important to have a proper diagnosis before the treatment. And with this, dear colleagues, I would like to conclude and to thank you again for your attention, for your invitation, and I would like to welcome you to Bern once it is possible, or I would like to visit you in Saudi Arabia, and you can see my email address, and if you have any questions, you can contact me, or I have now, since a couple of weeks, also Facebook account. You can contact me also via Facebook. I try to answer you. Thank you very much.
Thank you, Dr. Skolian, for this nice presentation. It's always good to see your cases and your documentation. I have I have a problem now. My hand is like this, and the clinic are closed. You know, I want to do something. And the second thing is I'm sitting home and I'm cooking at the same time, and I think I have to recook because I burned my food. Enjoying your lecture. Thank you very much. I will ask everyone to directly contact Prof. Skolian for questions because we're running late, and I have to close this session. Thank you, Dr. Skolian. It's always good. And probably we'll have you another time with a longer time or webinar so we can take more of your questions if you don't mind. And after me is Let me check who's Dr. Khulud Al Ali is moderating the next session. I would like to welcome her, and it's time for me to say goodbye, everyone, and enjoy the rest of the day.
Thank you. Thank you so much.
Thank you.
Thank you. Thank you.
Hello, everybody. On behalf of